Okay, good afternoon, everyone. Welcome to our webinar entitled Liver Wellness and Cancer. My name is Anil Seetharam, and I work at Banner Transplant and Advanced Liver Disease Center in the University of Arizona College of Medicine in Phoenix. As an outline of what we'll talk about over the next 40 to 45 minutes, we'll start with a discussion that's probably in front and center on everyone's mind, and that's the COVID-19 pandemic and its effect on liver health. And then we'll spend a few minutes speaking about hepatitis C, an older virus that's been around for a while, but certainly remains a cause for concern as well. Spend a couple of minutes discussing liver cancer or hepatocellular cancer, and then end the webinar with just some review or brief points on liver wellness. So to begin with, as we all know, we're about 2 months, at least in the United States anyway, into the COVID-19 pandemic. And so COVID-19, of course, is the coronavirus, which is an illness caused by the SARS-CoV-2 virus that is believed to have originated out of the Wuhan province in China in late 2019. Based upon world experience and unfortunately the United States experience as well, we know that there are certain patients that are at high risk for severe disease, and this would include patients who are older or geriatric, greater than 65 years old, those who have pre-existing cardiovascular disease, and risk factors for cardiovascular disease, such as diabetes or hypertension. Those with chronic lung disease, including COPD, are also at risk for severe disease. And so when we talk about severe disease from COVID, essentially what we mean is a very severe lung infection and inflammatory response that can sometimes lead to mechanical ventilation and a number of issues. What we're also seeing with the COVID-19 infection, and it's not fully understood, but there is a propensity for thromboembolic events or blood clotting that can occur with severe infection. And so this can include things like pulmonary emboli, embolic strokes, or even heart attacks. In addition, of great concern is the fact that it's known that COVID can be transmitted from asymptomatic individuals. So the virus is new, and it's not fully understood how any particular individual is susceptible. And although we know generally what the risk factors are, we know that there are people who could have acquired COVID-19 and felt perfectly fine. And while that's good for them, of course, it's a highly transmissible virus, and they can infect those around them who may not be as lucky. So when we talk about COVID-19 and the liver, it's important to note that from a molecular perspective, or at that level, we know that the SARS virus binds to human cells through something called the angiotensin converting enzyme receptor, or ACE2. This ACE2 receptor is also present in the liver, in the biliary tract. So the liver is a potential target for COVID infection. In looking at patients who've been hospitalized with COVID, the incidence of liver damage is variable, reported in some cases as low as 15%, and in others as high as 50% of cases. So we know that COVID can, in fact, infect the liver. What is unknown is that if patients do have chronic liver disease, are they any more susceptible to damage from COVID in the liver? That's something that hasn't fully been understood or appreciated yet. So how are patients with liver disease doing with the COVID infection? And the answer is that the data is being collected literally as we speak. As the pandemic was recognized fairly quickly, large registries and collaborations were set up to try and delineate and outline the experience of patients with chronic liver disease and COVID-19. And there's a registry in the United States titled Secure Cirrhosis, which I believe is based out of the University of North Carolina. And there's also a European registry, along with Asian registries as well. And so the Secure Cirrhosis and the COVID Hep registries of the United States and Europe has sort of pooled data and looked at the population of patients admitted and reported to hospitals with COVID-19 infection. And so in looking up this data, unfortunately, what's being reported, at least at this point, is that patients with cirrhosis or advanced liver fibrosis with COVID-19 may be at risk for more severe complications, and that includes the need for mechanical ventilation, the need to be admitted to an intensive care unit, and unfortunately, the possibility of death. Whereas the death rate for patients in the general population who acquire COVID may be around 3 to 4%. Unfortunately, in those with chronic advanced liver disease, it may be double that, around 7 or 8%. Now, I say maybe because we have to take these registry reports with a grain of salt, in the sense that this is a highly fluid situation with data being collected, and there is a possibility for a reporting bias. In other words, doctors reporting to these registries are seeing the sickest patients, those that come into the hospital. So we don't fully know the true epidemiology with respect to liver disease. What about outcomes in patients who've had a liver transplant? Well, again, what's emerging based upon what's been collected is that those who've received a liver transplant, again, may be at risk for worse outcomes. That, again, includes the need for mechanical ventilation, a need for a stay in the intensive care unit, and possibly death as well. What's also acknowledged is that the immunosuppression or the anti-rejection medicines that people take after liver transplant likely prolong viral shedding in post-transplant patients and probably make them more likely to transmit virus. And again, a fluid situation, but one that's being investigated, is that adjustments in immunosuppression therapy may be needed in our liver transplant patients. Now, that said, the AASLD did put out not really a position paper, but sort of a reference paper at the end of March, and I think it was updated in early April, where the commentary is that we really shouldn't be making anticipatory adjustments in patients who've had a liver transplant who don't have COVID-19 or any symptoms. And so, in other words, what that means is if you do have a liver transplant and you're taking anti-rejection medicines and you feel fine, you really shouldn't lower or stop taking your medicines, which may precipitate, of course, a liver-specific problem unrelated to COVID-19. I think another important point there is to be in close contact with your transplant center with regards to further direction with regards to these medicines. So what about management of COVID-19 in patients with liver issues? Well, through the news, we know that there's a number of agents that are under investigation for treatment, and various ones have gained popularity at various times during this pandemic. At this point, there is no silver bullet that will reliably reverse or attenuate disease. Different centers are evaluating different protocols, and different agents are being studied. And it's important to note that any of the agents that are used, the great majority of medicines and pharmacotherapies, are metabolized by the liver. So any of these agents may pose a risk of liver toxicity in and of itself. May not be a reason to not use them, but again, we're currently actively investigating potential agents to attenuate COVID-19 infection. In parallel with that, a number of vaccine candidates are being investigated, but there should be a caution in the sense that the vaccine discovery, testing, trialing, and development period isn't one that takes place generally over a period of weeks. So I think it would be overly optimistic to anticipate by July 4th there's going to be a COVID-19 vaccine for the nation to use. There will be many months ahead still of patient safety trials and efficacy, and then eventually efficacy trials. And so I think even in the wildly most optimistic expectations, there could be a vaccine next year, but at this point that is unknown. So our focus for patients with liver disease, just like everyone else, is to really hone in on the preventive measures of what we can to decrease transmission. So of course that means frequent hand washing and good technique when hand washing as well. And so the recommendation is at least 20 seconds of direct soap and water and rushing. Some people say the amount of time it takes to sing happy birthday twice. Remember also to be vigilant about cleaning frequently touched surfaces, as the virus can potentially exist on surfaces. And then the concept, of course, of social distancing as well, and minimizing interactions to the extent possible. And this includes avoiding large gatherings like huge sporting events, but also reviewing your needs to sort of leave the house and what's absolutely essential to be done and what can wait a few weeks. And there are a number of practical issues that have also emerged in the COVID era as well, particularly as it relates to patients with chronic liver disease. For those who are on the webinar who may have a diagnosis of chronic liver disease, remember that regardless of COVID, routine things need to happen to monitor your liver disease. And in particular, those with advanced cirrhosis probably know that about every 6 months to a year, they need routine imaging of their liver to screen potentially for liver cancer. And because of this pandemic, a number of routine imaging studies like the biannual ultrasound or the yearly CT scan to follow up on anything are being delayed. And so it's important to keep track of that for yourself and your provider to be doing that as well, so that when the opportunity does arise and things settle down, those imaging studies are rescheduled. In line with that as well are endoscopic screenings. So again, those with advanced fibrosis or scar tissue in the liver generally require an upper endoscopy once a year. Those over the age of 50 require colon cancer screening, generally performed with a colonoscopy, and those too have been delayed when it's considered screening or an elective procedure. So again, those need to be keeping track of both by patients and providers for an opportune time to do it later on in the year. And then, of course, the general clinic visits may be delayed as well. And an important point about that is that if your clinic appointment has been delayed because of the pandemic, it's important to touch base with your provider or their office to make sure that you have an adequate amount of refills for medicines that may expire within a 90-day time frame or something similar to that. And then also, we do encourage people who feel they're at risk for more severe COVID infection to have that discussion with their providers, because providers are in a position to advocate for telework options for those who are in need. This becomes particularly important if you've had a liver transplant and you are on systemic immunosuppression. Other chronic liver diseases where this may come into play are those with autoimmune hepatitis, who also require immune-lowering medicines as well to control their disease. From the perspective of liver transplant, and I work in a liver transplant program, similar to before, but perhaps more intensely, we are balancing risk and benefit daily, and this works on a lot of levels. We have a number of patients on our list, of course, who are in need of a critical life-saving transplant. And those who are most in need, as represented by the highest MELD scores, we are proceeding with liver transplants. In other words, our center, like most centers around the country, are not closed to performing liver transplants. But every individual case or patient on the wait list, their situation is looked at very closely, where we look at where they are in the course of their disease, and are we putting them at risk by bringing them into the hospital to have a liver transplant. So in the region, donor organs are tested for COVID, and of course all of our patients prior to coming in for a liver transplant are screened for potential infection as well. at some point, we hope and we believe that this pandemic will end, and we'll get through this. And I think perhaps like you and a lot of people are wondering exactly how's the world going to look like when all of this is over. And in particular, I spend a lot of time thinking about how our health system is going to look different after this pandemic is over. And I think one potential positive that has come out of this, if we choose to look at it this way, is that this concept of telehealth is being leveraged like never before. So for many years, there's been discussion about telehealth, and there's been a number of different platforms and technology that have allowed historically people in remote areas to access healthcare providers in a different location. And while that has been great, I don't think the uptake has been anywhere near what those who are involved in telehealth or those who potentially saw its potential would be without this pandemic. So now, even though someone may live just a few miles away from our medical center, to adhere to social distancing, to keep them safe, and to keep our waiting room and other people who may have to come in safe, we have been doing telehealth and televisits. And I think this is something that may be here to stay for elective visits where minor issues need to be addressed. But this is something that we'll have to evaluate in the future. As we sort of touched upon before, although COVID is at the forefront of the medical scene right now, all of the chronic conditions, whether it be a liver condition, whether it be heart conditions, lung conditions, whatever, they didn't go away just because COVID came. And because of our response to this pandemic, we're going to have this sort of huge backlog of not only elective procedures, but simply elective and routine maintenance care that was delayed. And now more than ever, regardless as to whether or not you've been touched by COVID, this is an important time to be advocating for your own health with your providers, not only your liver provider, but providers in all specialties and your general health provider. Keep track of things that you would have done in a normal year and make sure that those are addressed when appropriate after discussion with your provider. The other thing that I'll say with regards to how COVID has affected our medical system is just the way hospitals and institutions have robustly sort of developed policies for COVID that affect everyone. So to adhere to social distancing and best practice, keep in mind the patients that we have in our hospital who are COVID, they're cohorted or they're kept in separate floors, in separate ICUs. And so that's an institutional policy to keep people safe. But there's also, this has also influenced our elective procedures where patients who would be coming in for elective endoscopy have them performed in separate rooms. They're tested beforehand. And then also keep in mind that there's a number of visitor restrictions in hospitals across the country. So, and this is something that's very, very tangible and very real for families that has nothing to do with COVID. Suppose a family member is having a baby that, over the course of the next few weeks and, has to go through that process potentially with limited visitors. So, there's no one who hasn't been affected by this pandemic. And I think like all of us, hope it passes soon. And I think we're all doing our best to keep our heads up and support each other through what has been a very difficult time. So those are a few statements about COVID. Again, I think we could spend hours talking about COVID and its effects, but this webinar was meant to be sort of a top-level survey of some topics in liver disease. So we're going to shift gears now and talk about another virus that maybe not as popular as COVID at the moment, but has been around for a while, and I think something that warrants some attention. So hepatitis C is a chronic virus. It's an RNA virus, which isn't too important to really care too much about the detail, but similar to COVID, there's no immunization for it. And it's thought conservatively that about 3 million Americans in the United States are viremic, but that really is a conservative estimate. And so this is just a cartoon that describes the structure of the virus. We won't delve into too much detail with regards to that. So when we talk about hepatitis C, the first question is, when I meet patients who have been referred for hepatitis C, is, how did I get this, or how can someone acquire hepatitis C? And in the United States, the primary mode of acquisition is blood contact. So intravenous drug use is the leading cause in the United States. However, drug use just intravenously is not the only way you can acquire hepatitis C. So snorting instruments, even dollar bills, can potentially transmit hepatitis C. It's important to not to equate anyway, hepatitis C to simply a disease of intravenous drug use, because there's a number of other ways via blood contact that someone can acquire hepatitis C that has nothing to do with illegal drug use. And this includes skin exposures from healthcare workers through needle sticks, dental work, potentially, unprofessional tattooing, and then also blood transfusion as well. So keep in mind, hepatitis C was only molecularly characterized in the late 1980s. So if we didn't really know what it was, we couldn't test for it, and we couldn't test blood for it. So in theory, anyone who had had a blood transfusion before the early 1990s could be at risk for hepatitis C. Sexual contact as a mode of transmission for hepatitis C is rare. It's not zero, but it's exceedingly rare, less than about 0.5%, to the extent that the Centers for Disease Control actually do not recommend barrier precautions if someone is in a stable monogamous relationship where one partner has hepatitis C and the other one doesn't. Perinatal transmission, super common, but it's not zero. And our best estimates are that it can occur when the mother is viremic anywhere from about 2 to 5% of the time. So what happens when someone acquires hepatitis C? So if we sort of start up at the top, where someone, whether it be through blood contact, whether it be through needle stick, whether it be through sexual contact, is acutely infected and sort of labeled at time 0, it's important to note that about maybe 15 to 25% of the time, someone's immune system can actually clear the virus or get rid of all viral particles. And so when those people are studied, what's observed is that their hepatitis C virus level, and this is the actual level of virus in the blood, it's an RNA virus, so that's what we're checking in the blood, is negative or non-detectable. However, we know that they were at some point exposed to hepatitis C because they have a positive or reactive hepatitis C antibody. Contrast that with what happens the great majority of the time, where at time 0, through some mode of acquisition, someone is acutely infected, and about 75 to 85% of the time, they develop a chronic infection. When those people are assessed, what we find is, again, they were exposed, so we know that they have reactive antibody, but they also express, or what's demonstrated in the blood is actual levels of virus. So their HCV RNA is positive. This becomes important for patients because it's nice to have a basic understanding of what these hepatitis C tests mean. If you go to see a provider and they say, well, we're going to test you for hepatitis C, they'll likely start with what's called the hepatitis C antibody. And that test is simply a screen to determine whether or not you have been exposed to hepatitis C virus. What's generally required then, either in their office or after a referral to a provider who can treat hepatitis C, is checking the HCV RNA to detect actual levels of the blood. What's also important to note is, regardless as to successful treatment or your immune system doing it itself, once you are exposed to hepatitis C, that antibody remains positive for life. So I have a number of patients who have been successfully treated for hepatitis C. And a few years later, I get a call from them saying, hey, is it back? Because I saw another provider and they checked my hepatitis C antibody and it's positive. So that must mean it's back. And generally, I have to remind them that, that just because the antibody is still there or being expressed in the blood does not mean that hepatitis C is back. It was just a marker that that previous infection was there. And that to do a confirmatory test, we have to check the actual level of RNA in the blood. So this is where probably we can draw some distinction from viruses like COVID, although there are some similarities as well. So what happens when someone has chronic hepatitis C? Well, first of all, acquisition can be clinically silent, meaning that if someone acquires hepatitis C, they don't necessarily have to feel a bad way. This is usually unlike the case with other liver viruses like hepatitis A or B, where it's pretty noticeable. They develop jaundice or yellowing of their eyes, or they may feel very poorly. Oftentimes when someone acquires hepatitis C, the symptoms are very general or nonspecific. They may feel fatigue, or they may just feel a little bit low, maybe have some joint aches. Some people describe a brain fog. But in general, there is not a classic huge liver inflammation response where there's jaundice or they end in the hospital very sick. And then sort of the natural history of what happens next can play out over a period of sometimes 20 to 30 years. If we start sort of here at time zero where someone acquires hepatitis C, it enters the bloodstream, the virus, and then enters the liver, and it starts creating inflammation. And this chronic hepatitis, where there could be no signs or symptoms, no one feels particularly bad, could last for 20 years. And in that time, it's important to note as well that the level of inflammation at any time could be very variable. So a patient may see a doctor once a year for those 20 years, and they may get a liver panel checked. And those liver enzymes may be normal, the AST and ALT. So there's really nothing abnormal. There may be nothing really to investigate, and the liver damage could go unabated. But if that liver damage is allowed to progress over a period of 20 to 25 years, the liver's response to the chronic inflammation is to lay down scar tissue. And if that scar tissue burden becomes high enough, generally we say that the liver becomes cirrhotic or filled, and going from large and smooth to somewhat shrunken and filled with scar tissue. And the development of cirrhosis really represents a tipping point, where once cirrhosis develops, there's a risk for associated complications that happen when someone has cirrhosis. And this includes the development of a primary liver cancer, hepatocellular cancer, other what we call decompensating events like variceal bleeding or ascites, and the chance for possibly death. So knowing that, how many people with hepatitis C actually go down that pathway? And the answer is if hepatitis C is sort of left untreated, yes, there are a lucky bunch that won't go all the way to cirrhosis, but it's very difficult to predict who those people are. And so it's thought that of the people who acquire hepatitis C infection, like we spoke about earlier, a lucky 10-15% will clear it, but most people will develop a chronic hepatitis. Of those people who develop a chronic hepatitis, maybe about a third of those will end up needing or developing cirrhosis, an advanced scar tissue. And of those people who develop cirrhosis of the liver, about a third of those will develop potentially a liver cancer or end-stage liver disease requiring transplant. So not everyone with chronic hepatitis C will suffer a very severe liver fate. The truth is we don't know who necessarily will do well with the virus and who won't. So it sort of behooves us to try and eliminate it once it's identified. Because the complications of end-stage liver disease are very severe and life-threatening. And so this is just meant to be a pictorial of some of the common complications that develop when someone has advanced cirrhosis. This is a representation of an upper endoscopy where we see in the esophagus or the food pipe, a vein in the esophagus, literally pouring blood. And this is what's called an esophageal variceal bleed. And esophageal varices are veins that develop in the throat when someone develops cirrhosis. Oftentimes there can be no signs or symptoms of these veins in the esophagus, so no difficulty swallowing or no chest pain. But if it occurs, it can be a catastrophic complication. And then, of course, there's ascites, or the development of fluid in the abdomen, which occurs when someone has cirrhosis. Certainly an uncomfortable situation to be carrying around a lot of extra water in the abdomen. And then a very feared complication, which we'll spend a little bit more time speaking about towards the end of the webinar, is hepatocellular cancer, or primary liver cancer, that can develop when someone has advanced fibrosis of the liver. So just to summarize this bit about hepatitis C, acquisition of hepatitis C can be silent. In other words, there may not be a lot of symptoms. So we as healthcare providers, have to be very proactive in searching for hepatitis C. And in addition, as patients, we need people to be aware and advocate that they get tested. And when we talk about who really should be tested for hepatitis C, the answer is really everyone. In particular, the baby boomer cohort, or those born between 1946 and 1964. So although you may have no signs referable to liver disease, a one-time screening test for hepatitis C is extremely important because, again, the liver damage can be very silent, and identifying it can make all the difference. Progression to hepatitis C or to chronicity is common for those who acquire hepatitis C. And again, just to review, liver damage can occur under the radar, can lead to cirrhosis, and if you have cirrhosis, a number of complications can develop. So the good news is highly tolerable therapy for hepatitis C is available and can cure everyone. It can halt progression of disease, and we're beginning to believe now that hepatitis C treatment, regardless as to when it's applied, can potentially stabilize and reverse liver damage that was thought to be fixed or already done. So just to touch upon, review that important point, as far as who should be tested for hepatitis C, I would advocate that everyone be tested for hepatitis C. And it's important to get the message out there, particularly if you're of the baby boomer generation, to get that one-time screening test for hepatitis C, but also spread the word with your friends as well, so they continue to spread the word. Because the issue is really not about treating hepatitis C anymore. It's about identifying everyone who has it. And when it is identified, as healthcare providers, we don't want you to be afraid of the process of getting your hepatitis C treated. So I just wanted to spend 1 or 2 minutes just talking about what that might look like when you go and see a healthcare provider for hepatitis C treatment. So one of the key elements that will happen once a patient is diagnosed with hepatitis C is they may be referred to a healthcare provider, and the healthcare provider will make an assessment of liver fibrosis. And that process or that concept is called staging fibrosis. Staging fibrosis means, okay, so we have identified someone with hepatitis C. How do we determine how much scar tissue is in their liver? Now, historically, and what this picture is meant to describe are actual liver biopsies or pieces of liver. So towards the left here, we have a piece of liver that looks red pretty much across the way. And that represents a very healthy-looking liver. There isn't a lot of scar tissue. As we progress across this picture, notice how that the pinkness is replaced by these blue bands. And the liver, which was all sort of pink and continues throughout, is now sort of nodular. You see these circles of pink. This would be a liver biopsy of someone with cirrhosis, meaning that there's blue scar tissue that's sort of infiltrated throughout the liver. And the liver architecture has changed from being continuous and smooth to these nodules of pink material. So a liver biopsy was the historical gold standard of how to estimate how much scar tissue it is, but it's not Although a relatively simple procedure, it's not without a number of issues. One is pain and having to come into the hospital to get a liver biopsy. There is some risk with all procedures in the hospital, and no doubt there is at least some risk with a liver biopsy. But also, there is a possibility of what we call sampling error, meaning that people can go in and take a piece of your liver out, but there is a possibility that they hit a particularly good piece and underestimate the amount of scar tissue you have, or they hit a particularly bad piece and overestimate the amount of scar tissue you have. And so liver biopsy is sort of, I won't say it's become extinct, but it's not routinely used in the staging of hepatitis C anymore. A number of alternative modalities or non-invasive assessments have been made. This is a representation of a modality called a FibroScan, which is essentially a special type of ultrasound that many healthcare providers now have access to. And what happens during a FibroScan, it's a very quick and easy test, but essentially a patient lays on their back and a ultrasound probe can pass either shock waves or sound waves through the liver. And based upon those how those sound waves travel, the amount of scar tissue in the liver globally can be extrapolated, and we can make an assessment. It has been validated as a very good non-invasive assessment of how much scar tissue in the liver. It's used in routine practice, and so it's something that we use routinely in our practice as well. The only real preparation for it from the patient perspective is that it would be ideal if you are seeing a provider who is planning to treat your hepatitis C and staging your fibrosis, that you come to the appointment generally having not eaten anything for about 3 hours beforehand. Other components that may occur in the medical workup for hepatitis C include some blood work to globally assess liver function, assess immunity to other viruses like hepatitis A and B, for which there are immunizations and can protect you. And like we talked about, maybe making that assessment of fibrosis through other blood markers. Now, if scar tissue is established, okay, then a little bit more work may need to be done. And this includes an ultrasound or another form of liver imaging to screen for liver cancer, because although a FibroScan can estimate how much scar tissue in your liver, a FibroScan does not give you that full architectural picture to screen for liver cancer. I think that's another very important point, that the FibroScan is a technology to estimate scar tissue. It is not a technology to screen the liver for hepatocellular cancer, although they're both sort of considered ultrasounds. And then if there is advanced scar tissue, you should talk to your provider about having an upper endoscopy to screen for esophageal varices. When that workup is complete, you'll likely have a discussion with your provider about starting therapy for hepatitis C. And globally, the therapy for hepatitis C is identified as direct-acting antiviral therapy. And so these are pills or single-tablet regimens that work across all versions of hepatitis C, and generally are given once a day for no more generally than 3 months. Just of historical interest, there were a number of certain populations of people that were where it was considered very difficult to treat their hepatitis C. And for all intents and purposes, those days are over. So people who have been treated before with older agents or interferon, they can be treated very well now with direct-acting antiviral therapy. Same is true for those who have advanced scar tissue in their liver, who have HIV, who have end-stage renal disease, and are on dialysis. There is a medicine available for anyone with hepatitis C. I think, again, the key is to make sure that hepatitis C is identified. And, of course, gaining access to hepatitis C treatment as well, which, again, is a little bit beyond the scope of today's discussion, as kind of just surveying big picture ideas. And so with that in mind, we're going to shift gears, and in the last part of the webinar, spend the last couple of minutes talking about liver cancer. Remember, this is a feared complication of advanced hepatitis C infection that has led to cirrhosis. So when we talk about hepatocellular cancer or primary liver cancer, it turns out that this is actually the 5th most common cancer worldwide and the 3rd leading cause of cancer-related mortality. So it's common and it's deadly. The average age of presentation is around 60, although there is some high variation, with a slight male predominance. Unlike some other cancers, where the incidence over the last 2 decades has been decreasing, the incidence of hepatocellular cancer has been increasing for the last 20 years. So we're seeing it more. And it's projected to increase until at least 2030. So if I leave you with no other point as it relates to hepatocellular cancer, let me remind you that if you have a diagnosis of advanced liver disease, the doctor has told you you have scar tissue or cirrhosis of the liver, it is very important that you be enrolled in an HCC screening program. And so I want to spend a few minutes talking to you a little bit about what that means, HCC screening. So first of all, when we talk about screening, that concept, what we're saying is, of course, is that a patient doesn't have liver cancer, but we want to implement some strategy to identify and make sure that they don't develop liver cancer, or that because they're at risk, or that if they do, it's caught at a very early stage. And essentially, that's what we mean by screening, I think, in this context. We're looking because we know it can happen, and if it does happen, we're going to catch it at a time where we can make a difference. So there is a lot of medical literature, and sometimes it can be very confusing because there is some debate regarding, okay, what is the right interval? What is the right technique to screen? And what is the role of blood tests in screening for liver cancer? So one of the major professional societies in liver disease recommends that, sort of as a first step, patients with cirrhosis generally should be given an ultrasound every 6 months. Okay, and that interval comes from some data that just looks at the normal sort of doubling time or growth pattern of hepatocellular cancer. 6 months seems to be an appropriate interval, that if you have a good ultrasound within 6 months, by the time that you repeat it 6 months later, it's very unlikely that hepatocellular cancer would have grown to the extent that the management plan would change. Now, that said, can it happen? Yes, it can. Can it not grow at all? Yes, it can. There's high variability. What about what modality? In other words, this is the test that the doctor would use to screen you for liver cancer. The great majority of patients with cirrhosis generally receive an ultrasound, and there's a number of reasons for this. An ultrasound picture of the liver, one, it's considered very safe. It's a very easy test to do. It's just passing sound waves. It's not particularly uncomfortable, and it's extremely cost effective. In other words, most patients, regardless of where they live, with regards to proximity to a major medical center or not, have access to an ultrasound. So it's safe and it's cost effective, but there is some degree of what we call operator dependence, meaning if that the ultrasound technician, or by chance the radiologist who is doing the procedure, isn't totally skilled in demonstrating or doesn't have excellent technique in placing the ultrasound probe a certain way, there is a possibility that something could be missed. In addition, ultrasound may lose some sensitivity and specificity in patients who are particularly obese. Remember, if sound waves have to travel through a large body habitus or more weight en route to take a picture of the liver, they may decrease the quality of the image as well. So in some instances, the modality has to change, and that may take the form of what we call cross-sectional imaging of the liver. So this isn't an ultrasound, but this is a picture, and this can take the form of a CT scan or an MRI. A CT scan, and many patients on the webinar may have had a CT scan where you pass through sort of a donut, which formats a picture of the liver, or an MRI, which is a bit more enclosed and claustrophobic. These cross-sectional images are more expensive. They require contrast or medicines through the IV to highlight portions of the organs of the liver. And of interest, they also have to be multiphasic, meaning that more than one picture needs to be taken. So they're a little bit more involved. In other words, they're a little bit more specialized. And so they generally have to be done at an imaging center that has that capability, or a medical center that has experience and protocols in liver disease. What about tumor markers? And really, when we talk about liver cancer, the tumor marker that gets the most attention is a blood test called the alpha-fetoprotein. And there are a number of providers that check alpha-fetoproteins, but it's important to place those results in context. So the alpha-fetoprotein by itself is very nonspecific. And it's important to keep in mind that upwards of 10 to 15% of liver cancers don't express or elaborate alpha-fetoprotein into the blood. As such, no one should receive a liver cancer diagnosis on the basis of a blood test, the alpha-fetoprotein. It can be suggestive, but really the next step would be those imaging tests that we're talking about to investigate the possibility. Because it's known that a number of chronic inflammatory liver diseases can elevate the alpha-fetoprotein. Depending on the lab that's used, the alpha-fetoprotein normal, quote-unquote, normal range may be in the single digits. I can introduce you to a number of patients with issues like chronic hepatitis B and chronic hepatitis C that have an elevated alpha-fetoprotein that I've known for years that have no signs of liver cancer. There are a number of other sort of tumor panels or other blood tests that are under investigation to add sensitivity and specificity to the alpha-fetoprotein, although those remain under investigation and are not widely used in routine practice. When we talk about curative treatment for hepatocellular cancer, remember, liver cancer, if caught early, is one of the cancers that you can cure, and that cure generally requires surgery. For small lesions or small hepatocellular cancers in patients who don't have cirrhosis, there is an option that could include hepatic resection, or removing part of the liver and the tumor with it. For those who have advanced scar tissue but are within criteria for a liver transplant, they can potentially receive that liver transplant. And that fixes two problems. One, it removes the cancer from the liver, but it also removes the cirrhosis and the associated problems that come along with it. It's important to note that surgery, curative surgery, whether it be hepatic resection or liver transplant, are not options for everyone, but it doesn't mean that therapy can't be offered or that there isn't hope for liver cancer. And I put this slide up here not to overwhelm anyone, and please don't strain your eyes trying to look at everything, but the only point I want to bring out from this is that there are a number of non-surgical treatment modalities for liver cancer that are developed and available for patients really in all major cities and really all states across the nation. And these procedures are generally done by interventional radiologists. So these are radiology doctors who are specialized in procedures. And these include radiofrequency ablations, microwave ablations, procedures called chemoembolizations or radioembolizations. These are all relatively non-invasive procedures where access is gained through veins in the body, and wires and catheters are snaked up to the liver. This is painless, and chemotherapeutic agents or other agents are shot directly into the liver to kill cancer cells. I can say we have tremendous experience with this at our medical center, as do several medical centers. These are generally outpatient procedures, and they generally, for the most part, have excellent results that can extend both quantity and quality of life. And in addition, they can be used as an adjunct to keeping people within transplant criteria, even if they're beyond it. And transplant, just to go back to that point for hepatocellular cancer, is actually an indication for over a quarter of all liver transplants. And survival after liver transplant for once having had a cancer is excellent, with excellent 5-year survival, similar to any other indication for needing a liver transplant. Another area that I'm very excited about is systemic therapies for hepatocellular cancer. So like we talked about, surgery may not be an option or may not be the right option for every patient with hepatocellular cancer. Interventional radiology therapy may be offered, but again, may not always be right for every patient, but I'm very happy to say that we've entered an era where systemic therapies or oral chemotherapies are now sort of exploding for the treatment of hepatocellular cancer. For many years, we had one agent, Nexivar, and a few years ago, we received its sort of cousin, Stivarga or regorafenib. And over the course of the last few years, the armamentarium has only grown with other medicines that have demonstrated efficacy against hepatocellular cancer. So this is just meant to just review the fact that medical therapies for hepatocellular cancer are growing as well. So that was a brief review of hepatocellular cancer, and we're essentially running out of time. So I wanted to take the last minute or two and just review sort of common day-to-day questions with liver wellness. I probably answer these questions, I would say at least one of these questions on a weekly basis. And I think it's just always nice, since we're together on the webinar, just to review. Many questions, many people are asking now, particularly in this COVID pandemic, what is the role of supplements as it relates to liver health? And I just want to mention again that most supplements that you receive, even in reputable stores, are not FDA approved. So I caution everyone to please, before you embark on any potential supplement therapy, to review that agent with your provider. Oftentimes providers have access to databases to look up clinical issues with a particular agent to see if anything's been reported, and I think that's an extremely important exercise. Importantly also, we cannot recommend anything from a supplement perspective that would have any sort of prophylaxis against COVID infection as well. What about issues as it relates to diet? And I think, and again, this is fairly simplistic, but important always as a reminder that a low-salt diet is our major recommendation in patients with advanced liver disease. Okay, so if you're told you have a diagnosis of cirrhosis, one of the key things that you can do to improve your quality of life is to restrict your dietary sodium. A lot can get better simply with that. And even if that doesn't do the trick to getting rid of all the potential fluid that you have, it may make the medicines that the doctor works to remove that fluid better. Also, very importantly, if you have a diagnosis of cirrhosis, it has now been debunked, and no one should be telling you that you should be restricting dietary protein. In fact, quite the opposite. There's now a growing body of literature that suggests when you have advanced scar tissue in your liver, there are signals throughout the body to actually break down muscle and lose muscle mass. Protein, high-quality protein, is needed to maintain that muscle mass. And then lastly, this isn't just true of people with liver disease. I think this is true of all of us in a sort of a pandemic and stressful time. Remember the powerful sort of pleiotropic or wide effects of daily aerobic exercise. Whatever you can do to get outdoors, if you can, or indoors on a treadmill, or whatever you have access to, aerobic activity, 30 to 60 minutes a day, 4 times a week, can go volumes to your overall liver and global health. So that completes this afternoon's webinar. I really want to thank you for your attention, and please stay safe, and I look forward to talking to you soon. Thank you.